Okay, so my name is Lynn Haddad, and this is my lovely partner, Jahan Corbin. As you just heard, we are recording this presentation for bragroups.org, and in a couple of days, you will find it on the BRA Groups website under events. And so you don't have to screen and take notes if you hear anything that any particular information. Dr. Mudumbi, want to make sure I say your name correctly. I wrote down the phonetic pronunciation for your name, has a wealth of information to share with us. And so you'll be able to watch back the video at your leisure. And we do this because we have a lot of people who want to join, but everybody's not available at lunchtime. So thank you for joining us. If you can all keep your microphones on mute, we would appreciate that. As you heard the playback, it's distracting when people hear background noise. You can use the chat feature on Zoom if you would like to ask a question, or you can try waving at us. And we've got my laptop on gallery view. We'll try to pay attention, but the chat feature is actually the best way to put a question in if you'd like us to ask a question on your behalf. And with that, I will turn you over to Jahan.
Okay, thanks everybody for your patience today. It's good to see you all. I'm glad you're joining us. So I think most of you are familiar with Breast Cancer Recovery in Action. Just a quick kind of high level view for those who may be new to the group. BRA, you can insert your supportive pun in there. BRA is our acronym, but BRA is primarily a community of people who have navigated breast cancer and are survivors, and we try to connect people with others who have gone through a similar experience. But there's three primary components to our program. I like to call them the 3 E's. There's exercise, which is done in a group setting twice a week. And then there's education, which BRA Banter falls under that education umbrella. We also have nutrition information with our registered dietitian. We have lots of supplemental programs that might be, that are relevant to the breast cancer community. It might be about lymphedema. It might be about managing side effects. There's different education opportunities that go on. So exercise, education, and then the third piece is emotional wellness. And that looks like meeting in a group of folks, 6 to 8 people, usually facilitated by 2 survivors. And it's a 9-week curriculum. I like to say it's kind of like a book club meets a support group. And we work through a curriculum together and really delve into processing some of the emotions that come with a breast cancer diagnosis. So that's kind of a very quick summary of what BRA is and who we are and what we're about. Lynn and I are both survivors, and we consider it a real privilege to be able to facilitate Banter every month. It's a lot of fun. We hope to bring you really educational information, value-added content, make it worth your while, but also something kind of a spark in your day, kind of like a lighthearted hour of your day, even while we're learning something interesting. So it is my honor today to introduce our guest speaker. I am so thankful to have her. Is it Dr. Mudumbi? Did I say it correctly? Mudumbi. Okay. Dr. Mudumbi is a Nashville native, and she is the medical director of the supportive care program at Tennessee Oncology that does include palliative care. And if you joined today, you know that's our topic. So she's going to give us a good overview of what that is. She actually grew up in Nashville, which I feel like you're a unicorn if that's the case, because there are a lot of, there's so few Nashville natives these days, or it seems like that way to me. Went to medical school in New York and completed her internal medicine residency and fellowship at the University of Alabama at Birmingham. And Dr. Mudumbi, I have not told you, but I'm from Birmingham.
I'm not going to hold
it. Well, guess what? I am actually going down there to do a talk tonight.
Oh, are you really?
Yes.
Well, I hope you had a good experience when you lived there. That's my hometown. I've been out there for a long time, but I have a soft spot in my heart for Birmingham. And I went to undergrad at Alabama in Tuscaloosa, so we have that as well. But she loves to bridge the gap between community practice settings and academics with innovative health services and outcomes research. I can tell y'all just from speaking to her a couple times on the phone, she's smart as a tack and just has so much to offer, but it's also very relatable and like a real person. You know what I mean? Which is really nice, because sometimes we hear these bios of doctors and they're so impressive, but then you're like, are you a human? But you're very relatable, which I think is great. And so before I kick it over to you, I'm going to share the fun fact that you are a life coach for female physicians. That's so interesting.
Right.
That is
Yes.
really interesting. I love that. Thank you for being here today. We're honored to have you. To get us started off and into learning more about palliative care, do you mind just kind of telling us how you got into this field and what you most enjoy about working with patients in such an intensive focus on their quality of life?
I would love to. First of all, thank you guys for inviting me. This is one of my favorite things to do is just kind of educate, the cancer community and just people in general about palliative care. And so I really appreciate the invitation. So it's interesting as far back as I can think, I've always been like dually passionate about relating to people, connecting with people, and at the same time, really into science and health and medicine. So it is like, when I look back, it's no surprise that I ended up in palliative care because I feel like that's exactly what I get to do every day. I connect with people. I offer them loving presence and an intensive focus on their quality of life. And at the same time, there's the medical part, which includes, like the fancy term for it is symptom management. So, and that's anything head to toe. I explain to people, it could be pain, it could be your mood, it could be sleep, all the things that affect you day to day as you're living your life. So that's how I explain it to people is actually, I'm here to focus on all these things, your day-to-day routine, everything that's impacting your quality of life, while your oncologist focuses on the best treatments for your disease and taking care of the cancer. Um, so yeah, so I've always been, interested in both the human side and the science side of medicine. I actually was a theology minor when I went to St. Louis University. So I've always also been interested in like spirituality and how people find meaning in life. And so palliative care is kind of the perfect intersection of that, because when people face a serious illness, all of a sudden that becomes the big question, right? And that's a lot of what I get to talk to people about over time. Yeah, and then, as I was doing medical school and training, there was also a lot of experiences I had where I realized, people don't ask these big questions often enough to think about what gives them meaning in their life. What's a good quality of life? What are they willing to do for this, to achieve meaning and a good quality of life? And so, yeah, palliative care was just such a natural fit for me. And it's one of those things that, of course, we're talking about palliative care within oncology and cancer care, but it's really appropriate for any serious illness. And that includes illnesses like heart failure, like severe heart failure, COPD, even, chronic kidney disease. There's all kinds of serious illnesses that people face where palliative care can make a really huge difference in their quality of life. And actually, the latest research shows that it even helps with improving survival for people. And I know in our prep call, we talked about a great way to help people understand more is to kind of remember this tagline that it's appropriate for any age and any stage in a serious illness. Because that's probably the most common question I get from people is like, oh, is it only for the very end and things like that? And absolutely not. I take care of like plenty of survivors, people just going through their treatment and in their survivorship phase that still deal with quality of life issues. And it really is appropriate for any age and any stage.
Why do you think there is such a disconnect? Like, I mean, I can say that neither Jahan nor I had ever considered seeing is the correct term palliative care physician? Is that how we would refer to
Yes.
you? I mean, we both have been through, right, treatment for breast cancer. We both have had quality of life issues. It was never mentioned to us, never considered seeing a palliative care doctor. So there seems to be a disconnect, and it's such an important set of skills that you offer. Do you have any thoughts on where this disconnect is in the treatment world? And I mean, I think we've been
Oh,
very
such a good
fortunate
question.
in
Yeah.
having top-notch care.
We have,
I mean,
but I mean, I will say even, I mean, I consider myself to be educated and relatively informed.
right.
I will say, and this is just admitting my ignorance here, but truly I would have said that palliative care is almost like on par with hospice. That's
Yeah.
kind of how I thought of it. So obviously we're
I
wrong.
think that's
That's the
fairly
misconception.
typical in the
Yeah.
world. And it's like been shocking just in 2 weeks that you've transformed my whole thought process.
Yeah. So, it really comes from many dimensions. And actually, this is what a lot of my research focuses on is like, here's this wonderful service. Why aren't people using it more, even though all the research now shows of all the better outcomes when you incorporate palliative care? So it's a very complex issue, but I'll share with you some of the top reasons that I think, we're still dealing with this problem. The main thing is it's a new field. It's a new field. It's really only 20, if not maybe closer to 30 years old. And when you think about like medicine as a whole, like specialties like cardiology or nephrology, they're much older. People know, oh, this person takes care of the heart. This person takes care of the kidney, you know. And so it's a new field. So a lot of people don't, it's still kind of nebulous to some people, especially actually some of the physicians who have been practicing for a long time. They actually are not as exposed to palliative care. So that's the first dimension, like the primary physicians kind of tackling your care. They may not even be aware of the full benefit of involving palliative care early, you know? And so that's one thing. The other thing is, since it is kind of a newer specialty, there's not a ton of us. So there is kind of like a workforce shortage and capacity issues. So, I see that a lot in the community, like outside of academics, is that people say, well, that's great. We'd love to refer all of our patients to palliative care, but there's not enough people to, like I can't remember the latest statistics, but it's like there's one palliative care physician to like, I want to say hundreds, if not thousands of patients that may need it. And so it's a very, steep mismatch of, the people that need it and the number of physicians. Now, there are ways we overcome that, which is we use a lot of nurse practitioners and physician assistants on our team because I strongly believe that palliative care, it comes very naturally to nurses and frankly, other disciplines beside physicians because it's very, focused on the human in front of you, right? And that's like such a core principle of nursing and some of the other disciplines in medicine. And so we're very strong believers in kind of having a team-based approach. So you'll see often that there's a physician, but they, will work with 5 or 6 nurse practitioners who are able to then extend the capacity. So that's usually how our teams are structured, especially at, where I am at Tennessee Oncology. We have nurse practitioners who, provide wonderful care and are able to help us deliver more of this service to more people.
Do you
Yeah.
mind if I ask, are the nurses on your team specially trained in palliative care
Yep.
or are they?
Yep. Yes, absolutely. So they get their initial credentials and then we do a whole, set of training and communication, and focused on symptom management when it comes to like in our practice for cancer patients.
Oh,
So, and even, we also do something called advanced care planning. Have you heard of that before? It's like thinking through the what ifs when you're dealing with a serious illness. So, if I couldn't talk or think clearly and I was so sick that I couldn't get better, what are the things that are important to me? So, like, kind of thinking through the what ifs. They're also called advanced directives or living will is another name. So, we'll do a lot of that. So, we train all of our team in how to have these nuanced conversations and things like that. So yes, absolutely. They go through extra training to deliver this kind of care. Yeah.
I
So
think
yeah, I
I,
mean, back to your original question, it's like, not only do healthcare providers not know about it, and then we deal with capacity issues, and then there's like the public stigma, right? And so like a lot of what you see on TV and things like that kind of alludes to this being like a service that's for the very end of life, right? And
Mhm.
so even when our oncologists sometimes will explain it to patients, they still say no because they're like, I'm not ready for that. Even though we say, it's not it's not for a certain scenario. It's because you're having pain or
Right.
these types of things that we want you to get help with. And so there's a public stigma around it too. And that takes a long time to overcome.
Right.
Yeah.
Uh, I think, did I see you, Judy? You have a question or, yeah, go ahead.
Yes, I just wanted to share a quick story. I'm a Tennessee oncology patient, Dr. Hemphill. Are you familiar with him, doctor?
Yes, of course.
Okay. The hormone blocker caused tremendous hot flashes. I could not sleep. And so 2 years ago, he kept recommending something off of Amazon. I don't know if that's a man thing or what, but he finally said, I want to educate you on something, palliative care. And I'm like, am I terminal? And he's like, no, 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 no. Let me educate you. He did. He set me up with Amanda McKenzie. Are you familiar with her?
Yes,
And
ma'am.
the first conversation, she said, there is a drug trending for hot flashes. Let's try it. I have been on it for 2 years. I mean, it worked after 3 days. So
Wow.
I
Yeah.
have definitely benefited from it. And everyone I know that I could share that story with that needs that kind of extra care, that's been my mission. So I'm glad you're here today to kind of explain it to all.
Miss Judy, that is such a good story. I mean, that
Wonderful.
happens over and over and over again. I swear, every time I walk into a new patient visit, there's this like kind of anxiety and tension, and then I kind of tell them, and we start talking, and it's like, oh, I needed this a long time ago.
And I
Right?
stay in touch with her, and we've had calls just to say, how's it going? Is it still working? And I even looked up this drug on the breast cancer uh, website, and it was one of those things. And a lot of women have those problems. There's probably other drugs, but this one works for me.
Yeah.
I'm so
Yeah.
glad. That's a great story.
Thank you, Judy.
That actually leads us to somebody else had a question in the chat. At what point, and this is, your doctor, Judy, in that story kind of said, hey, you've tried what I asked you to do. Now let's try something else. And Candy's asking, at what point how do you know when to ask for palliative care or to seek out palliative care?
You guys are just full of great questions. I love this. So I would say this, it's never wrong to even ask for a visit so you can know about what the service is. If even if you're not dealing with any symptoms, you can always ask for it. In fact, we did this big study, this big clinical trial where people with advanced lung or gastrointestinal cancers, we just said, let's just try to see, what if we just did an automatic palliative care referral where the oncologist is aware, we tell them, hey, this person would be eligible just because they have this advanced cancer that a lot of times comes with a lot of symptoms. Why don't we just do an automatic referral and see what happens? So then we would call patients, explain it to them and say, hey, would you like a visit? And if they said yes, they just came to that first visit. And even the patients that didn't deal with a lot of symptoms, they were so grateful to be able to know that there's a service where if I ever do come, have pain or anxiety or whatever, I know that I have, someone that I can reach out to that's just focused on that. Yep. And
It's just very
so I would
reassuring to know that you're there.
Yeah.
Very reassuring.
exactly.
I
Yep.
think a lot of people end up like myself. I see my internist for most of my issues now that I've completed treatment because I'm only in seeing my oncologist every, like 6 months or a year. And they're so busy once you're out of the treatment loop. And so she doesn't maybe have as much specialized experience with issues that were caused by treatment. And I love her, but I think there might be a benefit in seeing somebody who could treat issues that were caused specifically by cancer treatment.
Exactly. Exactly.
I mean,
And
it seems like that's kind of the one piece of the puzzle that's been missing.
Well, and it's a specialist.
Yeah.
It's somebody that's been trained in that specialty versus our internists are more generally knowledgeable.
Well,
Right.
and the other thing that I think is different is that we are asking all the questions that other specialists may not, or even primary care, right?
Right.
Like I do a full, like every single patient of mine, every time I ask about all of these issues that affect your day-to-day quality of life. So I mean, I'll just walk you guys through it because every time I ask about pain, every time I ask about nausea, I ask about bowel movements, your eating habits, your energy, your routines, your daily activities. How
Right.
is your social function, right? So like, are you working? Are you engaging with your friends and family, your relationships? I mean, a lot of these questions, I mean, I'll be honest, like doctors are not necessarily trained to, like generally in medical school, we learn about these questions, but the medical stuff takes priority a lot of times, but there's so many dimensions that are so important to being human and like living well, right? And so we ask about all of this, your mood, your sleep, any spiritual issues that are coming up. I mean, these kinds of questions, I think a lot of times, other doctors may not necessarily, have that as part of their routine and also may not have time to address all these things, right? And so I feel like that's another reason to at least, meet with a palliative care specialist at some point along the cancer journey. So that's part one is, just to know about the service is a good time to talk with palliative care. Another reason would be if you are having symptoms. So, pain, like any of those things I just mentioned, any issues with, pain, eating habits, weight loss, sleep, mood, any of those things. And so that would be another reason. And then lastly, what I was mentioning earlier about advanced care planning, that's a very nuanced conversation. I feel like, sometimes it can sound scary. And palliative care specialists are very well trained at making sure that this is an important conversation that we have, but that it's also not like stressful, right? And so I believe every single person, healthy or not, should have an advance directive. And so that's our, that's an important part of our visits is that we always make sure everybody has some type of advance directive or at least has heard about the role of that in healthcare, right? So that your voice is always represented in your care. And so that's another reason that, people may want to consult with a palliative care specialist. So I see some more questions. Do you guys?
Yeah. And I was going to just say this, and we had this kind of, we already knew that this would come up, right? We sort of anticipated this because we're just like all of you on this call. We're really learning about this and interested, but can you speak to the need for a referral to come see a palliative care specialist? And then what does it look like with insurance? Do you have any knowledge of the insurance situation?
Yes. So let me answer the insurance one first. So all payers cover palliative care. It's just like if you were referred to a specialist. So it's not primary care, but it would be like if your doctor referred you to a cardiologist or a neurologist, something like that, where it's a specialist. And so depending on the type of insurance you have, there may be a copay that's different than primary care. So it's like that. And so, yes, all payers cover it. And then the referral question, most often we get people that are referred from another doctor. Because when we say serious illness, that means there is, something going on where there's a specialist in charge of taking care of this illness, right? So If it's heart failure, there's a cardiologist, and they may end up referring the patient to us. But we also can have people that refer themselves to palliative care too. Yeah, we have that option open within our practice as well. Yeah, because sometimes the primary physician may not, think of it readily. And so we want that option to be available to people too.
Yeah. Okay, great.
Okay. So one of our questions that we have prepared, which I think you maybe covered on this a little bit, but when we're looking at the care you would provide to, say, an early stage breast cancer patient versus a patient who's living with metastatic breast cancer, what would the differences look like from that perspective?
That's such a
Broad
good
groups,
question.
we have both within our groups, and I know, it's different worlds in some regards, right?
Yeah, it is different, and there's also commonalities. The commonalities are that I do my head to toe assessment for anyone that walks into my clinic room, right? And so that is similar. I think what changes is that folks who have metastatic illness tend to have more symptoms. Not always, but they tend to have, more quality of life issues. So we're doing a lot more intervention, I would say. Whereas maybe an early stage person, it may be one or two symptoms that we're focusing on, but a lot of, we're focusing a lot more on, getting through treatment and kind of what life looks like afterwards. Whereas metastatic cancer patients, there's just a lot more things that we're dealing with. And so a lot more intervention and management. Mm-hmm.
Are
And
you?
sometimes one other thing I'll say is like, sometimes, I mean, it doesn't always depend on the stage of illness, but sometimes our folks with metastatic illness, I mean, they're really, thinking a lot about like meaning in their life, right? So a lot more of the spiritual discussions happen, a lot more of, what can I do every day to make this time count? And so there's a lot more of that conversation, I would say. Mm-hmm.
Yeah, that's kind of what I was
Mhm.
thinking of. Like, I would imagine a metastatic patient, if they are looking at progression, are you able to help them think in terms of a game plan, like a long-term plan, and
Exactly.
what
That's
that
exactly what
might
we
look like,
do.
right?
There's such an emotional health component to this that I had not considered. I was really thinking more along the lines of physical symptoms, which I know you also are managing, but it's really interesting to think about the emotional care. You almost sound like part therapist, I mean, in a lot of ways.
It really turns into that. And that's,
Yeah.
that is my most cherished part of what I do, is getting to connect with people on that level, right? Because most of the time they're not asked about, what's your emotional experience, which really frames everything, right?
Absolutely, absolutely. Well, I think that's what I
Like,
felt from you. It went from you in our prior calls. That's why when I was
yeah.
introducing you, I was saying you have this human aspect and this relatability aspect. Now it makes sense because you do that on a regular basis.
Oh, yeah.
And so I'm like, I sense that. I mean, I can totally sense that from you, which is great. I had a question about, well, we've got another question in the chat about patients that, do you accept patients that are not being treated by Tennessee oncologists?
So right now, no, just because we have we're so busy with taking care of, our internal referrals and stuff like that. I hope one day we can expand to taking everyone from the community, but right now, it is just people within Tennessee Oncology that we see.
Are there other, I'm not going to ask
Yeah.
you to recommend your competitors or anything, but are there other palliative care groups in Nashville that you feel
Yes.
would work? Okay.
Oh yeah. I will say this, most people within palliative care are very similar to me, very similar to everything that I shared with you so far about palliative care, very much focused on taking care of the human in front of us, not just the disease. And so there's several different types of programs. So let me tell you about that. So probably like the biggest misconception, about it being for a crisis or end of life really comes from the fact that there's like inpatient side of palliative care, which does, tend to be very crisis focused. Like when people are in the hospital, they're dealing with, some serious issues, even more so than what's going on, outside of the hospital. And so there's inpatient palliative care teams. So pretty much every hospital in Nashville has, in Middle Tennessee, has inpatient palliative care teams. And they are there just to help you through the crisis of what's going on in the hospital. And so for some people, it might be a pain crisis, like if they have terrible cancer pain and it's just so bad that they can't handle it outside of the hospital, they sometimes get in the hospital. And so the team there will help them through that. But a lot of times in the hospital, there are a lot of end of life type of discussions. So that happens within the hospital. And then outpatient, kind of like what we do at Tennessee Oncology, there's a couple of different models. So there's like in the clinic, which is what we do. We do clinic and we do telehealth. And so Vanderbilt has a palliative care clinic as well. And then Tennessee Oncology, and then I don't think there's any other clinic based palliative care programs. But the other piece of it outside of the hospital is what's called home-based palliative care. Now that, as far as I know, is all across Middle Tennessee. There's lots of different companies that are doing this. The top one that comes to my mind is one called Aspire Palliative Care, and they do, home-based palliative care. So this is really more appropriate for people who are more homebound, like are dealing with a lot of illnesses and they can't come into the clinic, And so that's a great fit for people who are more homebound. And that's not, all of these things that I'm telling you, it's not specific to cancer. It's for anyone with a serious or chronic illness. And so Aspire and, what a lot of the hospice companies have done is they also have a home-based palliative care branch within their company. So like Amedisys, I'm trying to think of some other names, but pretty much a lot of the hospice companies also have a home-based palliative care branch, where they see people, not necessarily, that are hospice eligible or anything, but just taking care of their quality of life for homebound people.
Are those physicians or are they more mid-level, or do you know like what?
Yeah, it's very similar to what I mentioned before, where, there's just such few physicians that are trained in this that generally it's a physician and then they have several mid-level or, advanced practice providers is how we say it, nurse practitioners or PAs that are on the team and help extend the capacity. Now, the home-based programs typically also have some other staff. They'll have like social workers, also nurses that'll, come and do home visits in addition to the nurse practitioner. So there's sometimes some additional services available too.
But for the person who is not a Tennessee Oncology patient right now, and they're not homebound, but they're thinking, I have been on aromatase inhibitors or hormone blockers or whatever, and I'm just feeling I've got all these, like Judy mentioned, hot flashes. I've got all these different things that are affecting my quality of life. Then do you think we can look around in Nashville and just try to find somebody near us without just call them up with a referral, or ask them if they require a referral? I guess we go through our GP or whoever.
Yes. Yeah. Yep.
Like, is it a board certification or is there like a particular certification that we're looking for to make sure that our doctor who's overseeing this group is well qualified?
Yes, that's right. So it is a newer specialty. And so what happened was in the beginning, there was just people who gravitated more towards this type of care. that
Mhm.
got grandfathered into this specialty. So they just had to take an exam and, like show that they had the skills to practice the specialty. And then they created a fellowship. This was about, I want to say 15 years ago, 15 or 20 years ago. And so more recently, what has happened is people go through fellowship training just to be trained in hospice and palliative care. And
Okay.
so, yeah, you can look
You
for
can see that
board
in
certification, yep, and
credentials.
fellowship training.
We like to research our doctors.
Yeah.
I like all the letters.
Yeah,
I want
Sandhya
all the
Mudumbi
letters
was our
after
thing.
mine, all the letters.
All the letters.
With all the things.
It's
Okay,
important business, you know?
it really is. Okay, what other questions do we have from folks, or have we, I'm sorry, I may have lost you.
Might mention some of the, oh, Judy, you first, and then I thought
Yeah.
we might mention some of the issues that we know that you can treat, just so that people understand the breadth of the areas and might be able to ask questions. But go ahead.
Doctor, I wanted to tell you, once I had the advantage of palliative care, my husband has prostate cancer. And so I mentioned it to him. We're in Sumner County. He called his doctor and got a referral. He's in remission now, thankfully, but they came mobile. And, his PSA is down, all the things that go with that. And once he got past some of the problems he was having with the medication, she kind of signed off, but said, hey, you need me again? Let's go back. But she was mobile and she came here every few weeks. We got so close to her that we felt like she was family. But she was not with Tennessee Oncology. I believe it was Aspire, but she was out of Hartsville. I just wanted to share that once I got educated on the
I
on
need
the
to take you
benefit of
around with
that.
me.
I was
I'm
gonna
like,
say,
"Geez,
she
that's
could
a
be like Judy could be your marketing
Yeah,
person,
you-
you know?
I know.
Yes.
I think
That's one reason I was on the call today, because I couldn't wait for others to hear about what a great benefit this is, and and the education of what it is.
Right,
So
yeah.
thank you for allowing me to tell that story.
Oh, I'm
No,
so glad
thank
you did.
We appreciate the real life experience. We
Absolutely.
do. All
And we've
right.
already admitted to you that we didn't know what it was. So we're
No.
really learning. I'm
I wish
appreciative
I
that you're
had.
here.
Well, and I'm interested in a couple of these areas. So when we were preparing for this, we talked about some of the topics that we might want to discuss. And so I just thought I would read it aloud to our participants in case it sparks any questions, if that's okay with you, Doctor.
Yeah.
Some of the issues that you do address would be using self-coaching skills in the cancer journey. And you mentioned that you are a life coach in principle for some patients to help with mindset. That's really important. GI symptoms, constipation, diarrhea, nausea. Medications can really do a number on the whole GI system. Depression, anxiety, appetite, advanced care planning, neuropathy, energy and function. I can tell you, talking to members of BRA groups, I mean, I myself have issues with neuropathy. I know many people in our groups do. Energy and function. Energy can be ongoing, much longer than anybody tells you it will after chemo. Everybody's like, yeah, 3-4 months, you're going to be back to normal. And it does not come back to normal for all of us. So I just wanted to read that list of topics because this is a wide.
We did miss the big one, which is pain, which I think we didn't have it on the list because we were going to try to cram it into today, but
yeah,
pain is probably the biggest, thing that we get referrals for. And probably, probably the most common symptom that we manage.
Right.
So that would be, I think, a good one to talk about down the line. Understanding pain. Yeah.
So I don't know if anybody on the call has anything they want to throw out, maybe quick questions. We're certainly not here to give specific medical advice, but if, anything you wanted to talk about, we could certainly try to address that.
Did you have a question?
I feel like,
go ahead. Go ahead.
I don't know your name. It says iPhone 8.
Unmuted. Yeah,
There you go.
Marissa.
Oh, yeah.
Oh,
that's
oh
awesome.
my gosh,
I haven't seen it. Your hair's grown back.
Pretty
you
good.
are- I didn't recognize you. You look great.
Oh, thank you. I was gonna say I'm with Tennessee Oncology, and since I started, it said at the end of my reports it says palliative care. It wasn't explained to me, so I'm kind of I didn't know you guys did all that, so I'm glad I
Yeah,
joined the
so
call.
that's a really good point that you're making. So let me make a distinction. So sometimes in cancer treatment, they will delineate whether a treatment is curative intent or palliative intent. Okay. And so that means curative means like we, are giving you this treatment to try to cure this cancer fully, versus palliative intent means we're choosing a medication that we want to improve your quality of life, but we're not sure it's going to cure. So I wonder if that's what you're referring to, because at the bottom of our notes, it always says
Mhm.
palliative intent or curative intent, but that is not the same thing as being referred to palliative care.
Okay.
Does that make
And
sense?
and I have stage 4, so
Mhm.
maybe that's why it says it. That's what I thought.
That may be why you should,
Mhm.
I mean, if any of what I'm saying sounds like something that might help you, you can
Mhm.
for sure ask your oncologist for a referral. Yep.
Okay, thank you.
Yes. Mm-hmm.
Good to see you, Marisol.
Nice to see you guys too.
Yeah. Anybody else? I
Thank
think,
you for that question.
yeah, that was
Yeah.
great. I think, to your point about the pain being the big one, I feel like just, from what we hear being around folks who are living with breast cancer or have been treated for breast cancer, the pain and the energy level, I feel like are the two biggest things that I hear. And I guess it sounds like there's a lot that can be done, but we just, don't
Well,
know.
and how do you know, like, or say, like, the neuropathy was one example I gave.
Yeah.
Like, how do you know if you should see you or a neurologist? Like, how do you know which doctor
Mm.
to see? It can be confusing, I think. Like, I guess.
Or even a pain
one-stop shop is
specialist,
the way I'm
right?
looking at it.
Yeah, sometimes people even get referred to a pain doctor, right? Which is it's a little bit different than palliative care. But yeah, I mean, really a lot of doctors are trained to deal with some of these symptoms by themselves, right? I think the special thing about palliative care is that it's all encompassing to do with your quality of life, and we do get to, like, if I saw you, for example, for neuropathy, I'm not going to just talk to you about your neuropathy. I'm going to understand who you are, right? And kind of what's important to you, rather than just the focus on, just the neuropathy. So that's kind of the difference, I would say, is, between coming to a palliative care specialist versus going to a different doctor. And they're all well qualified to
Multiple
treat.
issues at one time, right? Yeah. And how, like, do most palliative care physicians, do they ever deal in like supplements at all? Or it almost feels like there's a little bit of an Eastern medicine feel,
Yeah. That's such a good question. Yes. Yes, not all. It's not an essential part of our specialty, but a lot of us see that sometimes traditional medications, they also have symptoms, right? So I'll give you the most common thing, which is for pain, a lot of times for cancer pain, we use opioids. And then opioids have all these other side effects and they cause their own symptoms, right?
Yeah.
And they definitely have a role. When pain gets bad enough, they really can make a big, big difference. But what we, a lot of us, especially me, I have learned there's such a delicate balance of not causing more problems by giving, traditional medications, right? And so my specific approach is usually to try to, make a combination of non-medication and lifestyle approaches alongside traditional medicine. because there's roles for both, you know?
Mhm.
So actually, like energy is a great example. There's very few traditional medicines that I can just give you a pill and all of a sudden we have, all this energy. Energy is such a complicated thing. It can be related to your mood. It can be related to your diet, how much you're moving. Like there's so many things that play into that, we have to have like a holistic and, lifestyle type of approach to that symptom because that's what it is. That's what it requires.
Yeah.
So what's great though is that we kind of have this umbrella of what's called supportive care. So we have people that are specialized in palliative care, and then we also have an integrative health team. Have you heard of them, or maybe Mary Darden? Have you spoken with her?
Oh,
Yes. Yes.
yeah, she did an
Something for
educational
us,
event for
yes.
bra and supplements.
Yeah.
That's
Yes.
right.
That's right. So we're all under the same umbrella. So we all work together. So if I see someone that can really use a focus that's just on, lifestyle and wellness approaches, and even nutritional counseling, then I'll refer them over to our integrative health specialists.
Mhm.
And then we also have psychologists and counselors on staff. So if our interaction alone is not enough and they need more, intensive counseling and therapy, then we'll refer them to that too.
Mm.
Well, it's so appealing. I mean, I know Lynn was making a joke about you being a one-stop shop, but it is so appealing sometimes, to think about, because like, for example, you mentioned energy, but like for me, so sleep is a big issue. I have horrible insomnia since taking the hormone blockers. But my oncologist does not want me to take traditional sleep aids on a regular basis. And so kind of just thinking through that, it's like, to your point, it's like, well, how much medication do I want to take? Do I want to be taking something to make me to make me sleep when this medication is making me not sleep? I mean, it gets a little crazy, and especially for those, we've all been through a serious illness. We've all gone through a lot of meds, and you get to a place sometimes where you just are like, I don't want to take any more. So I love the idea that there are a lot of different ways of approaching it, and it sounds like you really, by taking time to get to know your patients, then you know exactly where they're coming in, like in terms of like their activity level and their, just their desires and those kinds of things. Like, I think that's really helpful.
Yeah. Well, you touched on a really important thing, which is it's actually like a medical, I wouldn't say disorder, but a phenomenon, something we classify, and it's called pill burden, right? Which is like, and everybody knows when you've been through a serious illness, all of a sudden you're on like 10 different medications. And then you come, if you came to a palliative care specialist and now I'm like, oh, I have 5 more things for you to take.
I know.
It's kind of ridiculous. And so actually a really important principle we practice in palliative care is called deprescribing. So sometimes people will come to me and they just kind of stacked on all these pills because this specialist gave them this person gave them this. And, especially when people have lost weight, they don't need a lot of those medications anymore. So that's one of the best things I can offer, I think, is like looking at this and saying, we don't need these anymore.
Yeah.
Reduce your pills.
It's simplifying their lives. I mean, really,
Yeah.
it's simplifying your life, which is valuable.
Yeah, because it's frustrating because I feel like half the issues I have came from toxic meds, which, yes, I know they saved my life. I'm very grateful.
Yes,
No doubts here, but they are the thing that caused the problem. So I don't really want to ask for more. And I don't really want to spend 90% of my waking hours managing my health. I would like to
do other things.
I just have other interests.
Yeah.
And so I really want to farm it out to somebody else just to tell me what to do, what makes sense.
Yes.
And, simple instructions. So I can get back to doing the other stuff,
Exactly.
I know it seems a little unrealistic because I'm an adult and I have to do it. But
No, it makes sense.
I'm tired of being an adult. So what's the answer to get more people in this field? I mean, I think you're understaffed. And
Oh, well, actually, this kind of relates back
right.
to my fun fact that I shared with you guys.
Yeah.
Which is, a lot of physicians are facing burnout. And so that, that's my outlet to try to, for lack of a better word, like saving our specialty and our field is because I know how much value it brings. And I also know that if we don't manage ourselves, our mindset, our emotions, that, you know, we can also burn out, right? That's part of the problem is that, you know, it doesn't, you know, lend itself to sustainability just because of inherently, you know, it can be really emotional. Like, so actually I'll just share with you guys, when we empathize to the degree that we do, what happens in our brain is that there's something called mirror neurons. So even though I'm not going through the experience, when I'm like extremely empathizing with someone, it's as if I'm going through it. Like my brain looks like I'm going through it, right? And so when we do that day in, day out, every day, there's consequences to that, right? And so I think more so than anyone else, my specialty, you know, there's some other specialties too that do this a lot, have to be so intentional about, you know, your time outside of work, how you manage your mind, so that we can come back and do it again to the same quality, to the highest quality, right? So that's sort of my relation to the fun fact that I gave you before is that, you know, I'm on a mission to kind of like preserve this because I know how much value it brings to healthcare, to patients. And so, you know, we just have to really be intentional about managing our minds and our emotions.
Yeah,
Absolutely.
I can see that. I was at a BRA event a couple weeks ago, and we had an oncologist, and we had some patients up on the stage, and they were talking about scan anxiety, which is very real. And he said, "Well, by the way, oncologists get scan anxiety too," and I believe it. I mean, he's a very caring person, and you know, oncologists they develop relationships with their patients, and I never thought about it before, right? But you would have to, if you're a human and you're
That's
taking care of
right.
people,
That's
right?
right.
It would be very hard to have that big of wall
To
in
compartmentalize
between.
in that way.
Yeah,
You said it
patients.
earlier, just how complex we are. I mean, we can't separate all of our emotions and feelings from our brain. We can't, I mean, you know, like there, to a certain extent, we might do it to function, but we are integrated humans. We have lots of things that complex, things that go into making us who we are. So
Yeah.
that makes
Yeah,
sense to me. I
exactly.
appreciate this. I've learned a
This is fun one-to-one.
ton. I've
Thank
learned a
you.
ton. Thank you so much for your time. Are there any final questions before we let her go? I wanted to remind everybody in October, we had our speaker, Dr. Park, was not able to join us because of a last minute emergency, if you recall. So we've rescheduled with him for December the 4th. So this is a little bit, it's 2 weeks from now. Like it's a little bit, or 3 weeks from now, maybe. It's a little bit sooner than we normally do, but we just
You
rescheduled
might
Dr.
be
Park.
tired of us, but that's too bad.
Yeah. No, but thank you, Dr. Mudumbi. We really appreciate you. And I'm so grateful for what you're doing. Thank you for your work.
Yes.
You guys for inviting me and allowing me to share about this.
Yes. So happy Thanksgiving to everybody, and we're thankful for you.
We are thankful for you. Have a good afternoon.
All right.
Bye.
Bye-bye.